Everyone. Hi, good evening, everyone. It gives me great pleasure to welcome all of you to another session for the Chest Council of India. And the topic today is severe asthma. I understand all of you had a session on difficult asthma last week. So I would reckon this is a continuation of what you learned, what you discussed the last week. As always, we have a wonderful panel with us, a panel of experts who are going to discuss facets about difficult asthma and severe asthma, which you face in your day-to-day clinical practice. The way this program is going to run is to start off with a short talk discussing the GINA guidelines by Dr. Abhishek Prajapati, followed by a case presentation or a couple of cases that I will present to put things in perspective. And then we'll have all the panel discussing various facets of severe asthma. Let me do a quick round of introductions. The people on this panel are not alien to you. You know them well. So my name is Dr. Raja Dhar. I head the Department of Pulmonology in CMRI Kolkata, and I am from Bengal. So that's me. We are very fortunate to have Dr. Murali Mohan with us. Just to mention that Dr. Murali Mohan stepped in at the very last moment because of a dropout, and I'm really, really obliged that you're a part of this meeting and you will add value to this meeting, Murali. Thank you for being there.
Pleasure to be.
The other panelists here with us are Dr. Neel Thakkar. Neel is from Baroda and is well known to CCI and to the entire country. We have Dr. Abhishek Prajapati from Karamsad. We have Dr. Eema Chaudhary from Meerut, and we have Dr. Suprova Chakraborty, who is from Ranchi. So I'm delighted that we have a panel which is more women-centric as compared to men, which I think is a very, very different facet compared to meetings that I've done in the recent past. So very, very privileged to be a part of a panel. We'll have the ladies outnumbering the men for a change, which is great. What we'll do to start with is to do a quick presentation with Abhishek. Dr. Abhishek Prajapati will do for us, and we'll start off with that without wasting any further time. Abhishek, over to you.
Thank you, Dr. Raja sir, for a nice introduction and a nice moderation. And thanks you, CCI, for giving me a chance to present my presentation here. So today I will talk about GINA 24 Severe Asthma Guideline, what's new in Step 5 management. So as far as the overview of these changes in the guidelines concerned, 24 GINA guidelines for severe asthma management at Step 5 have introduced several key updates. Revised criteria for diagnosing severe asthma, focusing on objective measures of lung function and exacerbation history. New recommendations for the use of biological therapies, including specific criteria for initiating and stepping down treatment, and guidance on minimizing oral corticosteroid exposure and using them judiciously as a last resort. So, as far as this diagnostic algorithm is concerned, they have made few changes, considering that spirometry will not be accessible to each and every physician or treating doctors in the world, and sometimes the PEFR only will be available, and sometimes that also will not be available. So they have emphasized the use of clinically assess the patient, and if spirometry or PEFR available, better to go. If it is not available, better to check clinically. And if all other conditions are ruled out, we can start the patients on empirical therapy based, empirical ICS based therapy. So they have the change that these are the few changes in the diagnostic algorithm. And as far as diagnosis is concerned, they have few little changes. And these are the revised criteria for Step 5 severe asthma diagnosis. Persistent alcohol limitation, objective measurements of lung function such as FEV1 or peak expiratory flow consistently below 80% of predicted value despite maximum inhaled therapy. Frequent exacerbations called 2 or more severe exacerbation requiring oral corticosteroids in the past year despite optimal controller medication use. And symptoms not well controlled, ongoing symptoms including daytime and nighttime symptoms that significantly impact quality of life and daily activities. These revised criteria focus on capturing the patients with the most severe treatment resistant asthma who require specialized step-up management approaches. As far as this treatment chart is concerned, there is no major changes from 2023 this picture. But in arrow circle here, there is asthma medication terminology has been changed to asthma medications including ICS here. As a reminder that all the patients with asthma should receive ICS containing therapy. Now, other key changes in step 5. High dose, as far as high dose inhaled corticosteroids is concerned, wherever it's suggested in the report, it states that it's only for a short-term use for 3 to 6 months to minimize the potential for adverse events. Add-on long-acting muscarinic antagonists, the reduction in severe exacerbations requiring OCS associated with the triple therapy was seen primarily in patients with a history of asthma exacerbation in the previous year. Severe asthma with good response to type 2 targeted therapy. Advice about reduction in asthma therapy in patients who had a good asthma response to therapy targeting type 2 inflammation has been updated and clarified with the highest priority to reduce and cease the maintenance oral corticosteroids if used. Some previous RCTs included a rapid ICS dose reduction in patients on biological therapies in order to induce loss of asthma control, but this is not relevant to clinical practice. And RCT has been emphasized in adult with a good response to benralizumab found that with randomization to MART, most could have their maintenance ICS formoterol dose slowly reduced. However, the findings suggest that in a patient with severe asthma, maintenance dose ICS formoterol should not be stopped. This study also provides support for use of MART in patient taking step 5 management. And as far as this role of pheno is concerned, the main role of pheno in the practice continues to be to help guide treatment decision in patients with severe asthma only. If we talk about acute asthma, although strong emphasis on minimizing OCS used to reduce long-term cumulative adverse effects, OCS are essential in management of acute severe asthma. However, the occurrence of any acute severe exacerbation should be prompt to assess patient thoroughly, optimize the asthma treatment, and consider referral for expert advice to reduce the risk of another exacerbation occurring. In adults, a small number of studies examined the oral dexamethasone 12 to 60 milligram given once daily for 1 to 2 days in children and adults. The relapse rate was similar to that with oral prednisolone for 3 to 5 days, and adverse events rate were similar. So here they have emphasized the role of oral dexamethasone. We can use it, but it's advisable to use oral dexamethasone for 1 to 2 days only. And if further more days are required for oral steroid, it's better to switch to oral prednisolone. As far as management of acute asthma in hospital and ICU is concerned, it's still under discussion. There are few changes in new recommendation for biological therapies. Not much, but they have specific criteria now provided for initiating and stepping down these targeted therapies based on clinical characteristics and biomarkers. As far as guidance on the use of oral corticosteroids, the GINA 24 guidelines emphasize the more judicious approach for use of oral corticosteroids in severe asthma management. Clinicians are encouraged to minimize long-term OCS exposure and leverage alternative treatments such as biologics to control symptoms and exacerbations. OCS should be reserved as a last resort for patients with the most severe treatment-resistant asthma who are ineligible for or unresponsive to biologic therapies. When used, the lowest effective dose should be prescribed for the shortest possible duration to mitigate the risk of adverse side effects. And additional advice to also updated about stepping down OCS when asthma is well controlled. And there has been emphasis of importance of personalized treatment approaches like tailored to individual needs, shared decision makings, addressing comorbidities, and ongoing monitoring adjustment. So, severe asthma is a dynamic condition, and regular assessment and treatment modifications are needed to ensure optimum control. So, they have emphasized on regular assessment, biomarker monitoring, and personalized adjustment in these newer guidelines. And as far as addressing comorbidities in severe asthma is concerned, they have emphasized personalized approach, integrated approach, screening and monitoring, and tailored treatments according to patient's need. And they have also given emphasis on patient education and self-decision making by empowering patients, personalized action plans, self-decision making, and continuous monitoring. So, these are to conclude, the 24 GINA guidelines emphasize the comprehensive approach for severe asthma management at step 5. It emphasizes a comprehensive, personalized approach that addresses the complex, multifaceted nature of this condition. We have emphasized the engaging patients by empowering patients through education, self-decision making, and personalized action plans is crucial for achieving optimal asthma control and enhancing the quality of life. Optimize therapy. The updated recommendation optimize the use of biologic treatments and minimize reliance on oral corticosteroids, aiming to improve outcomes and reduce the burden of adverse effects. And ongoing monitoring. Continuous assessment and treatment adjustment guided by objective measures and individualized responses are essential to ensuring sustained improvement and minimizing the risk of exacerbation. So with this, I will end here and over to you, Raja sir, again. Thank you.
The GINA guidelines. Thank you very much, Abhishek. I thought that was a lovely summary of the GINA guidelines. Some of the topics that you touched on there are topics that we'll discuss during the course of the panel discussion again. However, I think the way you've summarized the GINA guidelines puts in perspective the next session, which is mainly going to be talking about difficult to treat and severe asthma. What I'm going to do over the next 20 odd minutes, may hopefully a little less than that actually, is to talk a little bit about severe asthma and difficult asthma in the form of case discussions. Let me just share my screen 1 second. Yeah. So before I go on to the case-based discussion, just revising what you learned last week, when we talk about problematic asthma, we talk about it under the umbrella of 3 different terms: difficult to treat asthma, therapy-resistant asthma, which is also termed as severe asthma, and the third area, which is a no-brainer, which is sort of intuitive, is untreated severe asthma. And if you treat that properly, it either goes into a controlled asthma or it goes into a therapy-resistant asthma. So those 3 terminologies, but what we'll focus on is difficult to treat asthma and therapy-resistant asthma. So you would have seen these definitions, and I won't read through them. What I'll try and do is to put these 2 definitions in perspective and try and underline how these 2 definitions are different. So difficult to treat asthma is uncontrolled asthma with high intensity treatment, but where there is a gap either from the side of the patient or from the side of the doctor. And what do I mean? I mean, either the label of asthma is wrong, so wrong diagnosis, the patient is non-compliant, so poor adherence to treatment. You heard Abhishek touching on environmental triggers, so adverse environmental triggers continuing, psychological factors, or comorbid conditions. So it's not the underlying disease which is the problem here, which is the asthma. It is about other factors which we have just outlined on that definition, which makes the asthma difficult to treat. As soon as you go to severe therapy-resistant asthma, it implies that you've corrected all these factors. You've corrected the diagnosis, you've made sure that the label of asthma is correct. The poor adherence to treatment is no longer the case. The patient is now compliant and has the right technique. The environmental triggers have been taken away. The psychological factors we spoke about have been addressed, and the comorbid conditions, which we'll come to during the course of this talk, but more importantly during the panel, have all been addressed. So despite this, on high dose of inhaled corticosteroid, plus 2 of 3 controllers, and you can see some controllers outlined there, the long-acting beta agonist, the leukotriene receptor antagonist, it can be theophylline, there's LAMA, there's low-dose macrolides. So on 2 controllers, the patient is still uncontrolled. That's severe therapy-resistant asthma. And again, this outlines the different factors which need to be addressed in difficult asthma, either to make it stable, controlled asthma, or to go to therapy-resistant. And remember, poor medication adherence, inhaler technique being suboptimal, ongoing exposure, that's the triggers being present, comorbidities, and there's some outline there: rhinosinusitis, obesity, GRD, OSA, etc. Incorrect diagnosis. There are multiple differentials to asthma: upper airway dysfunction, cardiac failure, lack of fitness, so neuromuscular debility, etc. And of course, psychosocial issues that need to be addressed. So that's the definition of severe asthma based on the controlling factors, the amount of medication that the patient is getting. The ATS-ERS definition has also defined asthma similarly. Like we said before, patients requiring treatment with a high dose of inhaled corticosteroids, plus a second controller medication and or systemic corticosteroids to prevent it from being uncontrolled, or it remains uncontrolled despite therapy. So this is something I've said before and reiterated now. However, what I want you to remember is 4 different conditions which define uncontrolled asthma in the clinical scenario that you encounter in day-to-day practice. That's poor symptom control, and you can do symptom control just by looking at things like nocturnal awakening, daytime symptoms, number of days missed from school, etc., but also on the basis of questionnaires like the asthma control questionnaire, etc. The second is frequent severe exacerbations. The third is a serious exacerbation which warrants hospitalization or mechanical ventilation. And fourth, airway remodeling, which results in fixed airflow obstruction, and that's defined by an FEV1 of less than 80%. So remember these 4. They translate into severe asthma: poor symptom control, frequent severe exacerbations, serious exacerbations, and airflow limitations are the 4 that I want you to remember. This is a study we did 10 years ago exactly now. So this was an Asia Pacific study, which was questionnaire based, looking at 8 different countries. I present to you the triggers which seemed most common in India. So this is the Indian arm of the 8-country study. This was called the Asia Pacific Asthma Insights into Management, or the AP-AIM study. And I want you to look at triggers there which are common to our country. And there are some which are peculiar. So factors like air pollution, fumes, dust, ice strings, change of temperature in the way of change in weather, etc., are things which are classical to tropical countries like India and not so prevalent in the West when you read Western literature. And hence, this information is important for you to know when you ask about triggers to patients who come to you with asthma. Why are we discussing severe asthma today? Why are we spending 2 hours of your precious time discussing this condition? Let's try and find out how common this condition is. So this was a population-based Dutch study, and this is often quoted because it echoes with what happens throughout the globe. So 1 out of 5 patients are GINA 4, GINA 5 asthma. You just saw Abhishek describing the steps of GINA and the changes. So step 4 and step 5 GINA is the moderate to severe category of asthma, more in the severe category. That's 1 in 4 patients. If you now look at difficult to treat asthma, so people in GINA 4, GINA 5, but poor control of symptoms, that's about a 1 in 5. So about 17%, which is 1 in 5, 1 in 6 patients have difficult to treat asthma, step 4, step 5, but poorly controlled in step 4 or step 5. Take a step further, about less than 5%, so 1 in 20 is the number when you look at patients who have severe asthma, so GINA step 5 asthma, but despite correction of all the factors we spoke about in the definition in the last slide, they still continue to have therapy-resistant asthma. So that's less than 5%. If you look at Indian data, this is the conglomeration of 5 different studies from India, which have defined the incidence of severe asthma from 5 to 10%. We did a study in the eastern part of India where we found that about 1 in 10 patients, about 9.1% of the patients had therapy-resistant asthma, which echoes with what is available throughout the country. Let me come to 2 quick cases. I've got about 10 minutes. I'll go through these cases quickly. The important factor is for you to remember the ethos of the case, the carry-home messages from the case, rather than the details, and then we'll come to discussing some of these facets during the panel discussion. So take this gentleman, he's 37-year-old, he's called Mr. Brajbhushan. He's had asthma for the past 4 years and is under the treatment of a general physician. He's been referred to you for repeated episodes of breathlessness and wheeze, which has happened on a daily basis, but he's had 3 exacerbations not requiring hospitalization in the last month. So daily symptoms, but symptoms requiring a doctor visit 3 times in the past month, and he's woken up from his sleep because of symptoms. He feels better when he takes a SABA. And again, this is something we'll discuss further on. This is a patient from about 3 or 4 years ago. You know that using a SABA in patients with asthma increases morbidity and mortality, and this is not something we would do after the results of the Sigma trial and other trials have been published. So remember this, we say feels better after taking SABA, but that's not something patients should do based on current evidence. He's currently on formoterol budesonide 200, 2 puffs twice a day through a spacer device. So think of the GINA guidelines and symptom control. This is the GINA assessment of asthma control in adults and adolescents. 4 different questions. Are daytime asthma symptoms happening twice per week or more? Are there any nighttime awakenings due to asthma? Is the patient using reliever medication for symptoms more than twice per week? And is there any activity limitation due to asthma? So remember, Braj Bhushan has daytime asthma symptoms on a daily basis. So definitely more than twice per week. He has nighttime symptoms. Yes, he has nocturnal awakening, as we said. We said that he uses the rescue. He used to use SABA, which would change now, but he uses rescue medications on a regular basis. We have not mentioned in that history whether this activity limitation or not, but then look at the categories of asthma symptom control. Well controlled when the answer is no to all these questions. Partly controlled is 1 to 2 of these answers being a sort of yes, and then uncontrolled 3 to 4 of these answers being a yes. And with 3 answers being right, you know that Braj Bhushan has uncontrolled asthma. Remember the term I'm using, it's uncontrolled asthma. We're not using terminologies like difficult to treat asthma or severe asthma as yet. This is a cycle that Abhishek showed to you. And without repeating what's been said already or what we'll go on to say even during the panel, there's 3 phases that you discuss. You assess the patient where you confirm the diagnosis, look at other factors like triggers, comorbidities, compliance, etc. You adjust treatment on follow-up. You have assessed, you've given the patient medications, you've assessed patient preferences and goals. You bring the patient back in 6 weeks to 8 weeks' time. You look at treatment of modifiable risk factors, non-pharmacological strategies, and you step up and step down depending on how well the patient's symptoms are controlled. And then reviewing response, which is further down the line, and you review how the symptoms, the exacerbations, the lung function has changed. Is the patient happy? Are the patient goals and preferences being met? And you do a lung function in some cases to see what's happening to the FEV1 in your patient. So when you're assessing, those are the questions you answer. You're making sure that the diagnosis indeed is asthma. You find out whether there's any concomitant cardiac condition. Is it really COPD rather than asthma? Obesity, muscle deconditioning, etc. And then mimics of asthma. Laryngeal obstruction, vocal cord dysfunction, etc. are questions that you need to ask yourself. Are there any triggers? And we showed you the Indian study, which looked at Indian triggers for us. Is he well adherent to treatment? Is the third question. Are there any comorbids? Is the fourth question. So this is the pictorial representation of what you saw in the AP-AIM study as Indian triggers. Mr. Braj Bhushan is a cook. He works in a dhaba and he lives in a room which is ill-lit, ill-ventilated, and is full of fungus due to poor plumbing. So when we say dhaba, you remember biomass. This person is exposed to biomass on a regular basis, and he's got a room full of fungi, which is one of the strongest triggers that you have for asthma in predisposed individuals. Important to check adherence because 75% of asthmatics are poorly adherent. And remember comorbids. We spoke about a few. Important to check the long list of comorbids in asthma. Unless you control these, asthma doesn't get well controlled. And in Mr. Braj Bhushan, he had significant gastroesophageal reflux disease. And unless you treat this, even with optimal treatment, it's unlikely that the patient gets better. Quickly look at the 5 biomarkers that we'll discuss again and again in the perspective of severe asthma today. So you're looking at total and allergen-specific IgE. This is biomarker for atopic asthma. You look at exhaled nitric oxide, which is a marker for allergy and Th2 inflammation. You look at blood eosinophils, which is the easiest to do marker that we have. Something all of you there on the listening to us, all of us have access to, easy access to. And blood eosinophil being used as a marker in some way changed the management of airways disease. And then the areas in research, periostin is a marker of Th2 inflammation. And with the new biologics coming in, you will hear more about serum periostin. and the sputum eosinophils, which has been there for a while, but it's difficult to do outside research scenarios. So remember the three: the total and allergen-specific IgE, exhaled nitric oxide, blood eosinophils, and we'll come back to these. So last 5 minutes, I finish off with another case. The last one I spoke about was in the area of difficult to control asthma. Remember, we had triggers which were not corrected. Remember, we had comorbidities which were not corrected in Mr. Brajbhushan. Now, suppose you have corrected the comorbidities, you've taken away the biomass, you've managed to put him into a clean, well-ventilated room without the fungus, the symptoms are still prevalent. That's what the case that I'm going to show you now entails. This is a patient I saw a couple of years ago. This is a 36-year-old female housewife who is resident of Shantiniketan. That's Rabindranath Tagore's home. A lot of you would have heard of this city, which is about 200 kilometers away from Kolkata. She has a long-standing history of asthma, no addictions, no secondhand smoking, no biomass exposure. She's overweight but not obese with a BMI of 27 and no comorbidities. She's had asthma for the last 12 years. At least she's had a diagnosis of asthma for the last 12 years, which makes her onset of disease at the age of 24. Remember, she's 36-year-old currently. She's got cough, expectoration, wheeze, coryza, and sneezing. She's compliant with her inhalers. She's got good inhaler technique. She's on good medication. She's on an ICS and a LABA. And initially, she was advised a dry powder inhaler for 2 to 3 years, even though we did not have records at the time. And when she came to us, she was a meter dose inhaler on which she had been for the last 1 year or so. And like I said, she was compliant and had good technique. She had history of exacerbation 1 to 2 times per year initially and was given on and off oral steroids. She would have about 5 courses of oral steroids in the 3 to 4 years before we saw her in clinic. The first time she presented in 2016 was when she had an exacerbation which required her to be admitted to ICU. She, however, did not need mechanical ventilation. After stabilization, the patient came to us on 30 milligrams of oral steroids. So was referred to us post-admission. She was about day 8 post-admission, and she came to us on 30 milligrams of oral steroids. At the time, she was still breathless. She was very wheezy, very tight chest, and she had continued to have cough and expectoration in spite of being admitted and in spite of still being on high doses of oral steroids. And we thought that we couldn't manage it at home, and she was readmitted for hospitalization. So we looked at her clinical details. We took a more detailed history. She had a very strong family history of asthma, as you can see on that slide. She had multiple comorbidities. So allergic rhinitis without polyps, allergic dermatitis, being overweight. We said BMI of 27, as you remember, gastroesophageal reflux disease, similar to Mr. Brajbhushan, and no history of anxiety. And then multiple triggers. These are things that she identified as a trigger for us. She said that she couldn't tolerate dust or smoke, which is sort of common to all patients with airways disease. Apple, she said she had scratching of the throat. She had some tongue swelling if she took an apple. And this happened about couple of minutes after she had a bite of the apple. She was allergic to cold. So air conditioning, low temperatures in air conditioning, she said, made her chest feel tight. And she was allergic to strong smells. That's the treatment she was having. I told you she was on reasonable treatment, high-dose inhaled corticosteroids in the form of fluticasone, a LABA in the form of salmeterol, a LAMA in the form of tiotropium, and she was on Montelukast 10 milligram per day. And she was on oral steroids for a recent exacerbation. We ensured that she was compliant to the inhalers, technique was checked, triggers were ruled out, and she did not have any symptoms. We did not do a sleep study in this individual because she did not have any symptoms. The serum IgE was raised. So now comes the main part. The serum IgE was raised in this individual, 635, as you see. The blood eosinophils were also raised, 470. So in your brain, when you think of severe asthma, think A, tick, she's atopic. She's got a raised serum IgE. Second, blood eosinophils tick. She's got a blood eosinophil count of 417. So she's on eosinophilic asthma. 2016, we did not have exhaled nitric oxide, and her lung function showed a moderate obstructive physiology with reversibility. We did a skin prick testing in this individual, and we found that she had house dust mite allergy. So it's very strongly allergic to house dust mite. She was not allergic to fungi, however, not mold allergic at the time. So what do you see? You see a young lady with asthma, 36, remember, allergic rhinitis, GRD, not maybe obese, but overweight, frequent exacerbations despite good inhaler technique, poor quality of life and symptom control, and been on oral corticosteroid recurrently in the years. 1 week to 1 month was the duration of steroids on multiple occasions. So these are rhetorical questions. I want you to think, what's the phenotype of this patient? We said the patient had high IgE, so that makes her T2 high atopic. We said that she had eosinophil counts of 417, so that makes her T2 high eosinophilic. So that makes her T2 high overlap syndrome. So you could either use an anti-IgE or an anti-eosinophil drug in this individual, which brings us to this question. How would you treat her? Would you give her an anti-IgE biologic? Would you give an anti-IL-5? So that's the anti-eosinophil biologic. Would you do thermoplasty and would you do macrolides? So overlap patient, it's between A and B. So what did we do with her? We controlled her, we changed the inhalers around. We ensured that she was compliant. Her exacerbation got controlled. We switched her to smart treatment. We continued her on tiotropium and we initiated her on omalizumab. You could do either. We chose omalizumab here to start with. She took omalizumab 300 milligram monthly for 1 year. She was weaned off oral steroids. Her wheeze resolved. Her symptoms improved. Exacerbations decreased, even though did not stop. However, she came back and told us, "Doctor, I'm much better now. I cannot afford the omalizumab anymore, even though I know it's something which is useful for us." This tabulates the number of exacerbations that she had, which required hospitalization in 2016 up to 2020. And you can see that while the number of exacerbations did go down, the number of hospitalizations had a much more dramatic effect as compared to those which were severe exacerbations, non-hospitalized, but requiring oral corticosteroids. So hospitalizations came down dramatically. The exacerbations came down a wee bit, but not dramatically. So after stoppage, the disease control got worse. Monthly exacerbations requiring oral steroids again. She was restarted on a maintenance of oral steroids. She had one severe exacerbation after a viral infection, which necessitated a hospital admission. And when we repeated her biomarkers, these were the numbers. So Ig, absolute eosinophil count still significantly raised. We had exhaled nitric oxide by this time, so a FeNO of 20, and the lung function was worse as compared to before. These are practical problems all of us face. I'm sure our elite faculty have faced these problems. I'm sure a lot of our listeners today, a lot of our delegates today listening in face these problems. She couldn't afford the drug. She did not have medical insurance cover. Her place of residence was far away. She lived outside Kolkata. And like we said, she lived in Shantiniketan, and there were multiple medical issues. And these were the options I had. Restarting omalizumab, trying an anti-IL-5, her eosinophil counts were raised. So you could try either Mepo or Benra, or you could offer her thermoplasty. So we did the best we could. We had an ongoing mepolizumab trial at the time, and we recruited her into the mepolizumab trial. She got better. However, I don't know what happens to her after the trial is over. There's two different trials that we have recruited her for. I'm not sure what will happen when the trial stops. And these are challenges that we face on a day-to-day basis. So two important messages. The effect of a biologic will wane after stopping the biologic, even in a very good responder, in a super responder. And patients with overlap phenotype can be considered both for an anti-eosinophil drug, so an anti-IL-5 biologic, or an anti-IgE. I'll stop there. I don't think we need conclusions just now because we have the panel now. So let's go to the panel. And if I could request all of our panelists to put their videos on. I can see there's questions coming in already. We'll address some of these questions as we go along. But let's start off with a question, which is probably the first thing that crops to everyone's mind. So let me start off with Eema. So Eema, in your clinical practice, we've shown numbers, but in your clinical practice, how common is severe asthma? And we're not talking about difficult asthma here. We're talking about severe therapy-resistant asthma. And how many people out of, say, 100 patients with asthma would you put the label of severe asthma in your practice?
Maybe three or four in my practice.
So 3 to 4 out of 100, you mean, Eema? That's the
Yes, sir.
number, so about 3 to 4% in your practice? Okay.
Yes, sir.
Let's, yeah, go on. You were going to say something, Eema.
No, sir. The
Yeah.
belt I am in, they are following and doing everything, and despite that, there are only very few patients who are either in the category of that difficult to treat or the severe resistant ones.
Sure. So low numbers, 3 to 4. That's actually lower than in my practice. Let's ask. So Abhishek, what percentage? You agree with Eema, 3 to 4%? Is it higher in yours?
So, as far as my clinical practice is concerned, and in practically, if I see during the seasonal variation, during to November to March, if I observe, then I will be checking 3 to 4 patients per month in this season of severe asthma. And if I in the later in the remaining period of the year, if I check, I will be encountering with the 1 to 2 patients per month of severe asthma. So if we check the exact definition of the severe asthma according to GINA guidelines, so most of the patient will fall in the difficult to treat asthma. So we have to check all the techniques. And
Sure.
then after ruling out everything, the patients remain under the this umbrella of severe asthma remain very less. So if I talk exactly, so 1 to 2 cases in remaining period of the year, and the peak years of the asthma when the BBC maximum patients of asthma and allergy, right, in fall season and winter and Diwali.
Sure.
And in that season, I'll be checking 3 to 4 patients per month
Sure.
of severe asthma.
Sure. So Abhishek, you gave a very important message, and Eema did the same. The fact that the distinction between difficult asthma and severe asthma is important. And while difficult asthma is far greater in number, severe asthma is smaller. Can I just ask you, when you say 3 to 4 and 1 to 2 in a month, tell me ballpark, how many patients of asthma would you see in a month? So 1 to 2 is out of how many?
1 to 2 in if I'm talking about, sir, I'm working in institute. So I'm talking as a department of respiratory medicine critical care. We are seeing the patient, not alone me. And so we would be seeing around 120 to 130 patients of asthma
Right.
in peak seasons. And we will be seeing in off season around 40 to 50 patients in off seasons. So these are number, not only my number,
Sure.
these are number as a whole of the
Sure.
department.
Yeah. So again, it's sort of less than 5% is the ballpark number that you're giving us, isn't it, Abhishek? So Suprova, another part of the country, how many? Similar as Eema and Abhishek, any different?
Sir, I will agree with Dr. Abhishek that difficult to treat asthma, especially in season, as Ranchi is totally surrounded with lots of greeneries. So, especially in the pollen season and rainy season and end of the winter season, see lots of influxes of especially difficult to treat asthma, which is greater than the percentage you said. It can be nearly 30%. But when it come back with all the correction and remodifying factors, then the actual severe asthma cases will be hardly 5%, not more than that.
Okay. Okay. So let me, so I work in a tertiary care center and have a referral base, and my numbers are slightly high. Let me ask Murali. Murali NH, one of the biggest sort of feeders, tertiary care centers that we have in the southern part of the country. Your numbers are similar to this. Mine, I would put my hand up and say somewhere between 5 to 10%, but I would like to hear what your numbers are. Murali, you're on mute.
So I'd agree, it's roughly 5 to 10%. It varies year by year. As I grow older, it looks like that number is actually rising. It used to be, as the younger set said, around 3% to start with, but now it's rising. It's somewhere between 5 and 10%. But we must remember some of these are overlaps with other conditions also. So pure severe asthma, probably closer to 7.5%, 5 to 7.5%.
Sure. Grand. So I think important to remember that these are small numbers. Hence, it becomes even more important to try and identify these cases because they need to be treated differently, treated as a separate group. And I think depending on how you work, where you work, the center that you work, the numbers will be somewhere between 3 to 10%, I think is the carry home message. Let me take the next question to you, Neel. So you see someone who's got difficult to treat asthma. And we are talking difficult to treat asthma here as opposed to severe asthma. You want to make sure that the patient does not have comorbidities before you put the label of severe asthma on that individual. So in your clinical practice, what are the things that you do? What are the conditions that you would check for before you say, okay, if there are comorbidities, I've controlled them. Now comes the question, is this controlled asthma or is this therapy-resistant asthma? Neel.
Thank you, sir, for the question. So, if we talk about, I think it's been discussed in the to some extent in the slides also. But when we are labeling a patient as severe asthma from difficult to treat asthma, we make sure that any other comorbidities are adequately treated or ruled out. Like if a patient has obesity, then we make sure that we have control factors to treat the patient has got weight loss, patient has got, if he has got obstructive sleep apnea, that is diagnosed and treated. Same way, if patient has a reflux problem, there are lifestyle changes, antacid medicines, there are other the measures for the GERD or the reflux are in place. Same way, if another allergy, as an example, patient has an allergic rhinitis, so if the patient needs intranasal steroids, or if a patient has chronic sinusitis with or without a polyp. So again, in either scenario, we have to address with specific treatment measures, and in cases where any surgical measures are also needed with a polyp, then that also has to be addressed. Same way, depending on what comorbidity the patient has, then that has to be added even with cardiac comorbidities. A patient, if you are treating as bronchial asthma, difficulty in breathing and refractory cough, has a recurrent pulmonary edema also, that also has to be adequately addressed. And as and when, as an example, in sleep apnea, if we treat it appropriately, then the asthma related quality of life as well as the frequency of symptoms of asthma will also improve. That has been shown in studies with sleep apnea as well as with GERD in both these cases. And in the allergic march, so if a patient has a food allergy, if any food substance which is triggering a food allergy, such patients, if we know the food trigger, avoid the food trigger, try to desensitize, then in such cases the overall there is a chance that the difficult to treat asthma may not progress to severe asthma. So
Sure.
addressing and treating the comorbidities is important. Thank you.
Sure. So Neel, very important points that you make. The fact that we are dealing with two different subsets here. One is triggers, and we mentioned some of the triggers during the course of the case. We'll come back to triggers again. The other is comorbidities, and you mentioned important ones. Now, some of the comorbidities that you mentioned, like obesity, like sleep apnea, these are independent risk factors for severe asthma. So aside from the fact that an obese gentleman will be breathless when they try and walk, the fact that you're obese adds to your risk of having severe asthma or uncontrolled asthma is the point that you made. And then there's other conditions. So heart failure, for instance, you made a point there. There'll be overlap between categories of patients with airways disease and cardiac conditions. And that needs to be focused on, is very, very important. Let's move on. Let me move on to Suprova. So Suprova, one of the biggest challenges we have, one of the biggest reasons we have difficult to control asthma is because people are non-compliant of their therapy. And more importantly, they are not good with their technique. So if you can share with the audience today some tips as to what you do to ensure A, compliance, and B, how do you ensure that you spend enough time or your team spends enough time with your patient to ensure that they have a good technique, is something all of us and people in the audience would like to know from you today. Suprabha.
Sure, sir. Thank you. For the first time diagnosed patient with bronchial asthma, first important thing, I think the counseling, explaining about the disease and the up and down of the disease, that this is not the final prescription we are giving him, how it can be totally controlled. And especially the assurance part is very important, that with if he follows the proper medication, how he can lead a complete normal active life. And especially some myths and misconception about the treatment part, which are very common regarding asthma, that has to be addressed. Because why the inhalers being used, especially describing them, why we directly use the inhalers which work on our lungs directly, and bypassing the bulk molecule, if the same we had to add in oral, and the severe accumulative side effect of that. And especially in a young patient who's when I show the PFT result directly, especially the low FEV1 value and after the bronchodilator reversibility, how much ml has increased, I think that elates them and gives them a lot of hope about the adherence part. It helps a lot. And first time, and the people who are not really convinced and spirometry is normal, I prefer to give them a peak flow meter in the form of breathometer with a form, so that they can self monitor, and when they take the inhaler, and they can self monitor how much peak expiratory flow has improved. So I ask them to bring back the that paper we give them morning and evening each time to measure it, the PEF themselves, and bring it back. That is another helpful method for adherence.
So,
And
Suprova, peak flow meter for every patient, or there's a
no,
certain category of patients you give it to?
certain category where it is patient has presented with mild symptoms and the spirometry is completely normal, no past history of severe exacerbation, and patient is totally, and no other very young age, no other comorbidities, and he's not convinced that he can really have bronchial asthma. Especially after counseling, we when I feel that it is necessary to do the from the first visit itself,
Yeah.
then those patients are provided. And
Sure.
for the technique part, sir, first time I show them with a placebo and a spacer device, and if the DPI device also, and ask them, please take the first dose in front of me. And consequently, every like follow-up visit, please bring your device and medication as well. So nowadays we have digital educator platform as well. So if the patient coming coming from far distance tend to forget like how the device was shown, they can record it, or they can just give a missed call or scan the QR code of the digital educator and can revise it again. So I think this technique
Lovely
somehow.
points, Suprova. Lovely points. One of the other things that I have found useful is to give examples of public figures who've done well with their asthma. So for
Yes, yes.
Bengal, for instance,
Priyanka Chopra,
Saurav
yes,
Ganguly is
yes.
a big sort of icon. PT Usha is a great icon. So I can see you smiling and nodding your head, Murali. So some top tips from your side to add on to what Suprova said about improving compliance and technique.
Yeah, so Suprova, that was excellent. I mean, I really have very little to add on, except a couple of things. The first is, each patient needs a slightly different approach. And as you come to know the patient, you've got to change your approach with the patient. Also, when a patient is more educated, a different approach, or less educated, a different approach. What Raja said about, talking about icons. So last month I had a young boy who's a swimmer. So you come out with Mark Spitz or, Michael Phelps and say, look, have you heard of them? He says, of course, he's my idol. And you say, he's an asthmatic and he's won 12 gold medals, 14 gold medals at the Olympics. And, so that's inspiring to them. For the older lot, it very often is somebody like Amitabh Bachchan or, a similar big figure. So that is one approach. You've got to change it according to the person. The second is identify the kind of non-adherence. So I remember reading a long time ago, there are 3 kinds of non-adherence. Primary, where the person doesn't take it at all. And that truly is a minority of patients. The second is the secondary non-adherence, where they take it, but they don't take the doses you've prescribed. So you prescribe 2 puffs twice daily, they take 1 puff once a day. And the third, of course, is the tertiary non-adherence, where they take the doses you've prescribed, but the technique, as Raja, you were saying, is poor. So that, Suprova has already told us how you need to monitor this at every single visit. And B, you've got to be prepared to change. If they're not using it because they don't like it, you've got to be prepared to change the device to something they like, they're prepared to use. And the last thing, of course, when you're talking about non-adherence is examining whether they truly are adherent. And that's the beginning part of this. When a person is non-adherent, you may not recognize it because he swears that he or she is taking it. So you need to ask this question, A, in a non-threatening way, B, look at the person accompanying the patient and see, very often they're sitting behind and shaking their head vigorously when this person claims that he's taking it. So be aware of these surrounding things. And a third question which often works is, how many inhalers have you gone through between your last visit and now? And you'll very often find they haven't been taking their inhalers. So these are some of the simple tips that you use to recognize non-adherence. And, I think Dr. Suprova has already told us how to handle the non-adherence part of it. And now we have such a wide variety of inhaler devices in India. It's easy to find something that, the patient is willing to use, able to use, and use in secret, because in India, that's a big problem, especially with young brides going into a new house. They don't want to tell people they're asthmatic. So we have to be prepared to dig out these things and address them specifically.
Yeah. So Murali, you bring out something which is important, the taboo part of asthma, with the label, with the fact that you're using an inhaler, the fact that you're using an inhaled corticosteroid and inhaler. All of these factors, I think, are something which is a part of the council. And I'm really pleased the way Suprova and yourself have brought out the facts. I'll come to inhaled corticosteroid. I've got a question in the box which I think is relevant to what we are talking about. But Dr. Vijay Kumar Chinnam Chetty has put in an interesting fact on the chat box here. The fact that 16.5% of Olympic participants from Europe have asthma. I think you can understand the numbers, the number of people who are achievers who have asthma and still lead a normal life. So on the similar note, I can see a question which comes from Dr. Arnav Ghosh from Kolkata, so from that city I live in. So he says, inhaler corticosteroids, do they have systemic side effects? So I'll give you two answers for this. And I sort of say this because I'm probably reasonably senior now in the category of practicing medicine. First, the fact that inhaled corticosteroids in dose above maybe a milligram of budesonide or equivalent is going to have some amount of systemic effect. And the same stands true for drugs like fluticasone, etc. But they are minute. But to me, asking as to whether inhaled corticosteroids have systemic side effects in a disease where the drug of choice by a distance is an inhaled corticosteroid is thinking about adverse effects of vaccines. I think it's similar. So if we as physicians worry about the systemic side effects of steroids given for a rational indication, I think you're probably depriving yourself and the patient of a treatment which is evidence-based. The thing to remember, of course, is not to go over the top, not to give doses of medications, inhaled doses of medications, which can potentially be harmful. But it's important to put the patient on the inhaled corticosteroid in the first place. There's another question, and maybe I'll quickly ask this before I go on. I'll ask this to Eema. Eema, there's a question about role of long-term azithromycin in the management of difficult to control asthma. So we're talking about step 5 asthma. Do you use azithromycin at all? And if yes, then what sort of indication would you use it for?
Earlier we been using for those COPD patients who were having frequent exacerbations. But recently I've seen an increase in asthma patients post URTI, the asthma exacerbations are there.
Sure.
So in those people who are repeatedly having such infections and are not improving or having effect on the quality of life, there I've started using and have seen the changes that yes, it does affect. It is helpful. But I'm yet to see them for long term.
Sure. So Eema, recurrent exacerbations, you're right. People getting recurrent exacerbations in step 5 of management with a reasonably low eosinophil count. There's 2 trials. The more recent one is called the AMAZES trial, which shows that use of low-dose macrolides at a dose of 500 milligram thrice weekly in the long term reduces the number of exacerbations. The AMAZES trial actually recommends it in both the eosinophilic and the non-eosinophilic category. However, because there's much better options available in the eosinophilic category of disease, it's more commonly used in the neutrophilic or the paucicellular category of asthma. So that's about the difficult to control asthma. Let's step into the topic for today, which is severe asthma. And let me start off with Abhishek. Abhishek, wanted to ask you, when you're trying to phenotype patients in step 4 and step 5, individualized treatment in step 4 and step 5, in your practice, what are the basic minimum tests that you would want to do in these individuals to try and phenotype them?
Yes, sir. So when we are phenotyping the patients of asthma, so in the background of our mind, we are also confirming that this is only asthma and this is not nothing else. So when phenotyping the asthma clinically, we are actually taking the history, first of all, to check, to rule out so many confounding or comorbidities. The patient is not dealing with the other factors like cardiac failure, or patient is having no any other respiratory factors which contribute to the symptoms of the patient. So history taking, then basic investigation, if we start with the complete blood count, with the eosinophil counts and neutrophil count, then our infective markers, then we will be doing ECGs to check for some organic causes of the heart failure or to rule out any other causes of cardiac etiology. Then we will be doing a CRP, we will be doing IgE, we will be doing IgG and IgR to check for the immunodeficiency syndrome. We will be checking for the fungal precipitants for including aspergillus. Then we will be doing a X-ray chase to check for another infective etiology. we'll be doing in some selected cases HRCT to check for if patient is having a phlegm. We'll be checking for the ABPA, and we will be ruling out that thing. Then on PFT, we will be confirming that patient is having asthma by confirming the reversibility and 200 ml or more than 10% or 12% reversibility. And then we move further. Then we will confirm echo to rule out the diastolic dysfunction. We will be doing a DEXA scan. We'll be doing a lung ultrasound to check for the other etiologies. And then we'll be doing, if we require, then we will move further. Then we confirm that patient is having a severe asthma. He will fall under the stage 4, stage 5. Then we will be go further for the type 2 inflammatory markers like blood eosinophil counts, sputum eosinophil counts, pheno, and if anything, if we have a capability, then skin testing and allergen testing. So these are the basic testing which will be required to confirm to phenotyping of the patients of the asthma.
Sure, Abhishek. So I think you have given a very comprehensive answer. We have covered various territories. So you've spoken about the area where you're looking for comorbidities. You spoke about heart failure, looking for NT-proBNPs, etc. So you've looked at comorbidities of asthma. Then you've looked at differential diagnosis of asthma. You spoke about ABPA. You spoke about doing a CT, looking for overlap with bronchiectasis, etc. So that's the segment of patients where you're looking for a differential diagnosis. And then you spoke about phenotyping. And of course, you spoke about eosinophils, you spoke about IgE, you spoke about exhaled nitric oxide, etc. So that's different baskets. A lot of the tests that you spoke about, so a bone DEXA scan, doing something like sputum eosinophils, are probably something you would do an ideal center in a tertiary care center and might not be required for everyone. Let me come to Murali. So I want, Murali, can I have a more compact answer? So basic tests for phenotyping. Maybe if we leave aside, Abhishek has very comprehensively discussed about things about asthma mimics, etc., about looking at comorbidities. But if you just think about phenotyping patients, what's your basic and what's your 2 steps above the basic?
So the basic is some of the things you did in the 2 patients that you spoke about, an IgE level, a total IgE, and often with that, an aspergillus specific IgE at the same time. That is something that some people recommend. I usually only start with the total IgE. Along with that, I would also do a eosinophil count, which is obviously a part of the basic workup. And based on these, we decide whether the person is an IgE dominant, eosinophil dominant, or the overlap of both these, which gives us the opportunity to choose a biologic if necessary, because in a severe asthma, you've done all the work that Dr. Prajapati has done, ruled out all the mimics, you've ruled out the comorbidities and handled them. Now you're really faced with this business of, should I use a biologic or not? And if so, which biologic? So that's really the basic.
Sure.
And of course, there's another group where none of these are positive, and that's a difficult group we'll have to approach later.
Yeah.
The other thing that I would often do is, at the same time that we are looking at these values, we would also look at the current state of control of the patient. And if the patient is not controlled, I would try and get them under control. So I would push them into a higher dose of inhaled steroids and maybe add on another drug and give them corticosteroids, ruling out other, making sure that I've got the person under good control, and then I'd start stepping down. We don't have access to the very fancy things like, the periostin and so on. So we are not going there at all. And in fact, we don't have access to sputum eosinophils. So we use blood eosinophils purely as a surrogate marker. We recognize that it's not always, it doesn't always correlate with the sputum eosinophils, but that's what we have. So that's really where we are. We don't go beyond that for 99% of our patients. And of course, you have the occasional patient where you'll be doing a CT scan and looking for, the comorbidities that Dr. Abhishek mentioned. But the other things that we often, do is bring our colleagues, the ENT colleague into play, and the gastroenterologist into play. And our gastroenterologist will be doing a 24-hour pH monitoring and a esophageal manometry. So those are the other special investigations that we sometimes resort to pick up on associated problems that we've not recognized till then.
Yeah.
But the history is king.
Yeah, absolutely. Great. Gives me great pleasure to welcome Dr. Krishna here, the founder, the daddy of CCI. Warm welcome. I'll come to you in a moment, Krishna. I've got a question for you, but before that, how do you position the skin prick test in all this, Murali? How would you position the skin prick test? Do you think when you're trying to define someone with atopy, is it something that you would do reasonably frequently, rarely, never at all? How would you position that?
I think it largely depends on the availability. When we had an allergy specialist who's unfortunately moved to the UK now, we used to do it fairly regularly. Now that the patient is not there, we're managing without it, but we feel the need for it. I think it's a very useful test at all stages and needs to be done more often. And now that SCIT and SLIT have moved earlier into the steps of treatment, I think it's important that we recognize the triggering agent very often.
Yeah. So when you're phenotyping, I think important for all of you to remember the CBC, the IgE, the exhaled nitric oxide, you've got access to it, and doing a skin prick test, along with the tests that Abhishek very vividly mentioned, which look at triggers, mimics, comorbidities, etc., are things that you need to sort out when you see your patient with difficult to control asthma, and then in phenotyping patients with severe asthma. Krishna Bhai, welcome. I was going to ask you a question which is slightly different to what we are discussing and then go back to the discussion again. I wanted to ask you, so there's such a lot of focus on heart disease, diabetes. We've got policies that come out from the government on a regular basis, but unfortunately, airways disease, especially asthma, where we have 45 deaths out of the 100 deaths happening globally. So 45% of the deaths happen in India. We still don't have a national policy in place. We don't have structured management policies for asthma and also severe asthma. So your thoughts, where do you think we should be going? Where do you think we are lacking in the drive initiative from our side, which will induce the government to come up with policies for diseases like asthma, which can be a killer if it's not properly controlled?
Namaste. First of all, hello to everyone. And Raja is someone, such a good friend that he drags me in spite of me not willing to go there. See how all you beautiful dressed up and look at my t-shirt, house t-shirt. So he drags me there. Whenever I don't want to come, he makes it a point that I make a guest appearance in his webinar, and I'm here. And thank you, Murali sir, that last moment entry. Raja told me that, can you bring Murali in? I told Murali sir, better you speak to him, because at 2 days notice, I cannot tell him. So thanks that he called and you arrived. And wonderful to have you all, Eema Behan, Suprova Behan, Abhishek, Chote Bhai, or Neel. Always lovely to see you. So answering your question, it has been like that. COPD has never been as important as CBD in our country. And what is unfortunate is they will tell you everywhere that I had a open heart surgery, I had a bypass surgery, I had an MI, but they are very scared to tell that I am having bronchial asthma. That's very funny in this country. And even that allergic part also, they will cover it beautifully that I have only dust allergy. They will not even call it as allergic rhinitis or bronchitis or something like that. See, regarding our government to make policies towards the respiratory illnesses, as you rightly quoted, regarding the bronchial asthma or COPD or anything, it is seriously recommended that for this, since probably 25 years back, I wrote an article, health article in Kannada language, that you can do whatever you want, but you cannot breathe a different air around you wherever you travel. See, something it is, you can buy a mineral water, which is expensive mineral water, and drink. You can buy a hygienic food and drink. But even if the president of America arrives to India, he has to breathe the same air, same quality of air, which others are breathing wherever he is sitting.
Very well put.
So this is a very important point, and we should understand, even the government as such, even the health sector people managing this, they should understand that, because oxygen is not replaceable. The air where you walk in, everyone has to breathe the same air. Let it be a pulmonologist or a asthma patient, or the chief minister, or the prime minister, or the president of the US. Everybody has to breathe that particular I don't know. Probably that day may arrive that when they carry like a cylinder for them to breathe when they come to India or when they go to a place. Now already those purifiers are popular. But however they are popular only at an indoor setup. When you walk out, you are forced to breathe that air which is there in the atmosphere, the polluted air or whatever it is. So very important thing is we should understand that not even the ratio, the size of the lungs are also huge than the heart.
Sure.
So,
No, absolutely.
because they play an important role, and it has to be taken serious consideration regarding asthma and COPD and rest of the things like tuberculosis taken into consideration because it is visible. See that suffering and that death is visible, but not so perhaps in most of these cases, which remains uncovered, which remains uncovered and not probably answered. So a decision has to be taken regarding this, and the day will arrive. But the problem is, we pulmonologists in this country are not microscopic; we are ultra microscopic in population.
Yeah.
So we are not a vote bank. We cannot influence any sector. So that is the problem. And however, people also consider that even nowadays that thought has come as everyone know that why even this branch is required also. So when that this has come, era has come, we should strongly think that we should tell people the necessity, especially the government sector, that it is there. From Chest Council of India side, being the founder and the chairman, I would strongly urge that a different dimension of looking at it is required from the government sector.
Sure. No, very valid points, Krishna Bhai. I liked all the points you made, but especially the one about pollution. Delhi is the hotbed of pollution, the most polluted city in the world. Our politics starts off in Delhi. There's so much of noise about the air quality in Delhi and the crops burnt and then the winds coming in and causing an AQI of more than 500. But there's hardly anyone ever who makes it a part of their election manifesto. Abolishing
One
pollution is
interruption.
never a part. Yes, Krishna Bhai.
One interruption. I used to write a series of such like funny awareness Kannada articles wherein it is like a discussion between the father and the child. I never mentioned it as father and son or daughter, father and the child. So innocent child's questions and how the father answers. So there I had written a tiny story that father comes home and he tells to the child, "Hey, we are going to Delhi next week. We are going there for a trip." Then the child tells, "Oh, Delhi, really? Okay, good, very good. But I heard, Papa, that there's a lot of pollution there." Then father tells, "Yes, yes, yeah, it is there." Then, "Papa, we should tell someone to control it before we reach there." The child tells. "Yes, we can do it," the father tells. Then, okay, to whom we can tell this? Someone who is sitting at the top. And where are they sitting, Papa? The child asks. They are sitting in the capital. Okay, and where is it? It's in Delhi. No, who is the head of this nation? It is the PM, the president. Someone else important? There's a Supreme Court also where you can go and ask these questions. And where are these people, Papa? The child asks.
Yeah.
They are all there in Delhi. Then aren't they affected? The child asks. Is that so? They are all in Delhi and they don't know about it. Come on, we should write to them. So this was a short story.
Yeah, no, absolutely. And I think these are important issues. I mean, chronic lung disease burden is massive. I agree with pulmonology needs to be much more important, but I think we are getting there. I think we are getting more pulmonologists every year, Krishna Bhai, and I think we will see a time when you will have the focus that pulmonologists deserve in the not so distant future in my book. We'll come back to the discussion now. Krishna Bhai, thank you very much for those words of wisdom. Thank you. And thank you as always joining in for my meetings. I'm grateful. Thank you so much.
And let's not forget that some of us are treating the chief ministers of their state.
Let me go to Eema. Eema, prognostication of asthma. So think about the two patients that I mentioned in my presentation. So patient comes to you in clinic. You've never seen this patient before. You make an assessment. You start on treatment, but then you think, okay, this patient might not do well, or this patient will have reasonably stable course with the medications I give them. What helps you to decide? What are the points that you look for, jot down in your prescription when you think, is this patient at high risk versus someone who might potentially remain stable if they do all the things we've been talking about in the panel?
So if there is a patient who is apparently looking as severe asthma to me.
A bit louder, Eema. I missed the initial part of what you said.
So if there is a patient who is apparently looking as severe asthma to me in my OPD, what I normally do is to get them nebulized in front of me.
Okay.
This is for the OPD ones who are not requiring the admissions, but I feel they can be better on my treatment. So if the bronchi actually go off, if the patient feels well in front of me, then I ask them to follow a different set of medications. And if they are not responding, then I either ask them to be admitted or add a few things, make them sit there, let me assess that they are able to follow it or not, including the points that Dr. Suprova has said, and then only let them go.
Sure.
So regarding your question regarding that, whether they'll do well or not, is based on my general assessment there as per how they are going according to my suggestions, whether they are able to apply to the facts, whether they are able to take the MDI with the spacer properly or not, whether the bronchi are gone after the nebulization or not, whether they're listening and there is a general perspective. Will this patient be adherent to what I say?
Sure.
So
Sure.
I follow those things and then only decide. Or else, if I feel the patient is educated enough, is able to understand everything that I'm saying, then
Sure.
I actually tell them about the points that if this happens, you need to meet me early.
Yeah. So very important point, Seema. You spoke about a patient who's uncontrolled when they come to you in clinic, and you're looking at the response to a bronchodilator in deciding whether they can be managed at home or not, right? And you very rightly spoke about scenarios where you look for compliance, you look at technique, you look at looking for comorbidities, and the capability and education of the patient in understanding what you're trying to convey to these patients, right? The other aspect, which probably we've not touched on as yet, is a patient who's reasonably stable when they come and see you. So this is not an uncontrolled patient. Patient has come to see you, is on inhalation. You'll see the patient for the first time, and you want to decide, is this patient going to do well? Is this patient not going to do well? And I think in deciding that, there are a few factors to remember. A, how many exacerbations does the patient have in the previous 1 year? And how many of these exacerbations required oral steroids? You would actually want to do a complete blood count in these individuals at baseline in trying to decide whether, in spite of the drugs that you're giving the patient, the eosinophil count is significantly raised or not. You would want to see whether the symptom burden, the daytime symptom burden, the nighttime symptom burden is high in these individuals in spite of taking the drugs regularly and complying with all the things that you've told them about, whether that's an issue or not. So I think those are factors. Maybe Murali can add a couple in. Murali, yeah, your thoughts about predicting the natural course of the disease in someone who's ticked boxes with compliance, technique, comorbidities, triggers, etc.
So one, of course, is the symptoms and the objective evidence. So there are some patients who are very poorly able to recognize symptoms. So if you look at, there are some people whose inflammation parallels their symptoms. There are some others whose inflammation is very severe who have no symptoms. That's a very dangerous group. They're very difficult to treat because they get worse and worse and they'll come to you only during exacerbations. You have people sitting in front of you who seem to be having difficulty in breathing, but he'll swear that he's perfectly fine and this is me.
Sure.
And there's another group who have, very high inflammation, but who don't have symptoms at all. I'm sorry, there's another group who have a lot of symptoms, but who don't have inflammation at all.
Yeah.
And that's another difficult group because they will not, be able to recognize when their actual symptoms are getting worse. Okay, so you have to recognize these three groups and you have to make this assessment in the beginning by a mixture of talking to them, understanding, as you said, exacerbations, how many times has he visited his doctor? It need not necessarily be an admission. It could also be, does he make frequent visits to the doctor for treatment? And we recognize that exacerbations beget exacerbations. The best predictor of a future exacerbation is a previous exacerbation. And of course, their baseline lung function. And if you can see somebody who's had lung functions in the past and they're showing a rapid downhill course, even if the person is feeling perfectly well, that's an alarm signal.
Yeah. So the over perceivers, the under perceivers, and then there's people who have got fixed airflow obstruction. That's also a bad prognostic one which needs to be remembered, isn't it? People with fixed airflow obstruction is bad. I'll stay with you, Murali. Another question which I think is actually quite difficult. You've got someone who is on a moderate dose of inhaled corticosteroid plus a LABA and is symptomatic. So on step 4 of GINA, which Abhishek told us about, you need to decide, do I hike the dose of the inhaled corticosteroid and keep the LABA, or do I add in a LAMA at this stage or a different controller? How do you decide? What tells you between these two options, which one to follow?
So if a person is typically atopic, has responded to good higher doses of inhaled steroids in the past, and now when I've been trying to reduce it, has had an exacerbation, the choice is very clear. You go for a higher dose of inhaled steroids, and again, keep them under control and then bring them down. However, if the person has not had the higher dose of inhaled steroids and shown a response in the past, it becomes a little more difficult. The person's IgE or FeNO or eosinophils are not very high in the past, in previous tests or currently. The choice becomes more difficult. If he doesn't have any of these atopic markers, if the person has a previous history of smoking, even though I've never demonstrated COPD, I'd probably be more tempted to add on anticholinergic, a LAMA.
Yeah.
And of course, the third group is where I'm getting a lot of nasal symptoms, which are still not very well controlled. In addition to that, intranasal spray, I might be tempted to add a montelukast, leukotriene receptor antagonist. So that would be my first level of choices: higher dose of inhaled steroids versus an LTRA versus a LAMA. And more we find, I think, that those who've had asthma for a long time, the LAMA seems to work better than just pushing up high doses of inhaled steroids. I like to emphasize to my colleagues a point that you mentioned earlier. 1,000 micrograms per day of fluticasone is high dose, and 200 micrograms a day of fluticasone furoate higher than that is high dose. We need to keep those in mind, and we need to try and avoid going to those doses. So I'd much rather use a LAMA in most patients.
Yeah, grand. Lovely points you made. Absolutely love them, Murali, about the distinction between increasing steroids versus the LAMA. You also made the point about looking at Th2 inflammation while on drugs. So a raised eosinophil count, a raised exhaled nitric oxide while on inhaled steroids probably indicates that the inflammation is not being controlled with the dose you're giving. And I think there hiking up the dose makes a big difference, which was a valid point. There was also a question in the question box, which we might answer now. You spoke about montelukast. There was a question in the question box about how long. And previously, I used to feel very secure in continuing the montelukast long-term in patients who had the overlap between allergic rhinitis and asthma. Now, however, we know about this FDA black box warning, which came 3 years ago about psychiatric problems, about suicidal ideation, etc. And hence, I'm more cautious about not giving it for more than 3 to 4 months at one go, giving it a stop and then starting again, and inquiring about psychiatric symptoms when they come for follow-up, if the patient has been continuing on montelukast for long. So I think those are points to remember. Let me come to Suprova again. Same question, Suprova. When do you actually increase dose of inhaled corticosteroid? And now I'm going to ask you about the other rescue medications. So add in the low dose macrolide, phenotype for biologics. Murali just spoke about the ceiling of dose of inhaled corticosteroid, be that fluticasone, be that budesonide. So what's your take? Someone who's a reasonably high dose of ICS, would you add in a LAMA? Would you phenotype them and think about biologics? How would you decide between the various options that we have?
Sure, sir. When asthma is persistently uncontrolled with a moderate to high dose of ICS LABA, preferably that ICS LABA should be switched over to ICS formoterol, MARD therapy first.
Sure.
And then there are some studies that adding LAMA modestly improve the lung function and modestly reduce the exacerbation, though it was not found with the symptom. With symptom control, some studies saying that not much of effect with LAMA, but it was evident that in the long run, lung function modestly improved and exacerbation modestly reduced. So that is a good point when we see even having type 2 inflammatory markers like high eosinophil, high pheno, maybe the asthma totally allergen driven symptoms are there, even if in presence of atopy, when after giving high dose ICS of 3 months trial, still there are frequent exacerbation or at least one severe exacerbation leading to hospitalization, or steady decline of lung function is there, so it should be advised to add a LAMA on that. Even GINA is recommending that even if we consider biologics after phenotyping it, it will be better first giving biologics to add on LAMA
Sure.
on these patients.
Yeah,
And
Suprova, completely agreed. Yeah, go on. Sorry.
And if for some patients, if we found that even moderately ICS LABA or ICS formoterol MART therapy, if the symptoms are more or less controlled, but there is a decline again in the lung function or not very much improved, and there is a history of OCS used in recent 3 months, they are also having a moderate dose, also we can add LAMA.
Sure. That replicates our practice, isn't it? I mean, having said all of what we are saying, there are financial constraints about using a biologic, and there's very few in the world who would not use a LAMA and go straight to a biologic. There will be very, very few people who would actually do that. So I think what you're saying is valid. There's also this category of patients where you phenotype and you find that neither are they Ig raised, so neither are they atopic, nor do they have a raised eosinophil count. And there the question of low dose macrolides come in, which we have spoken about. And there's lots of questions in the question box. There's also lots of questions. So my good friend Dr. Ajay Lanjevar and a couple of others have asked about thermoplasty, which again was used for this category of patients. It's no longer mentioned in GINA for a reason. The company has actually withdrawn the product. So the last license for the use of the product is 2025 May, and that's up on the website. I won't talk about the name of the company because it's not required, but it's up on the relevant company website that they will not be able to provide any of the probes post May 2025. We'll probably have thermoplasty in some other form in the future, but as of now, bronchial thermoplasty does not seem to be a practice which is going to be there in severe asthma, irrespective of which category it is. So I think that's about the categorization. Let me come to you, Neel. We've just completed 2 studies. Neel, Murali has been a part of one of them about blood eosinophils in our country. So we haven't actually published. I've just sent our paper over to the ERJ. I'm keeping my fingers crossed, but I won't tell you the results first. Let me ask you first. Do you feel comfortable using the Western cutoffs for eosinophils? We keep talking about 100 and 300 and 400. Do you think these are numbers that can be quoted for an Indian population with all the Helminths, etc., that we keep thinking about? Or do you think our cutoffs should be very different?
Sir, I feel that, sir, you would be the right person to address the exact data if you can share with us today. But actually, from whatever published data we have, in the ERJ only last year, there was a study by Benson et al. Which did compare the eosinophilic count over a meta-analysis with quite a 91 studies, which did show that overall the white and the Hispanic population, they have a relatively higher eosinophilic count compared to the non-white. However, even in that analysis, the number of Indian studies were only 2 to 3. So definitely we need your study and more studies in this data to give us some epidemiology regarding our own country, and definitely with the rate of parasitic infections, with also the rate of empiric use of drugs. Because there was by the Indian Pharmacopoeia in December, there was a warning published for mefenamic acid, which is used right, left, and center by a lot of patients OTC, over the counter. And still that is a warning that it can cause DRESS, that is drug-induced eosinophilia with systemic symptoms. So in the Indian context, normally what that study, the ERJ showed that patients who are smokers or ex-smokers with a age younger than 18, patients with allergic rhinitis who have significant fat deposits or higher obesity, these and patients with allergic rhinitis, these are all, and with high IgE, these are all patients who will have relatively higher eosinophilia compared to others. But definitely the Indian scenario, we need a different reference range for us, because at present we are following that only, that more than the ranges you have mentioned, that accordingly we are defining eosinophilia. So definitely we will have a more different profile based on the results, hopefully, which you can share with us.
Yeah, I will do very briefly, Neel. The problem is that we've got two studies, similar number of patients, about 7,500 patients in both studies. One led by Dr. Sandeep Salvi, the other led by myself. Equal number of centers, about 20 centers in each study. We found that the eosinophil count was not very different in the Indian population as compared to what it is in the West. There was a very small difference, but it was not statistically significant by any stretch of imagination. The other study, which is Dr. Salvi's study. Yes, Murali, go on.
No, go ahead. Complete your thing.
Yeah. The other study, which is Dr. Salvi's study, which is still a distance away from being published, they're writing it up. A study shows that the numbers are slightly greater, about 10 to 12% greater. Our study showed that the eosinophil count was greater in women as compared to men. And the numbers in women were actually greater than what it was in the Western population. No difference in the men. Sandeep's study showed something similar, but in men and women, the numbers were greater. In men, it was about 10% greater. In women, it was about 14 or 15%. The exact number escapes me, but somewhere around that range. So we'll have to put these. The studies were done with a similar design. We looked at asthma, we looked at COPD, we looked at normal individuals. Hopefully, once both the studies are published, we'll put the results together and we'll have a population of 15 to 16,000 patients, and we'll find out whether any difference is there or not. My gut feeling is there's not much of a difference. That's my personal bias. I'll call it a bias, because I think helminth infections are far common in younger children. We don't really see a lot of helminths in adult population, which we deal with. So Murali, your thoughts? You put your hand up.
So I was just going to say, Raja, this is a moving goalpost.
Yeah.
When I was an intern, we used to see a lot of eosinophilia, and the general population, the counts were closer to 4 to 6%.
Yeah.
Now I rarely see that except in asthmatics. The normal population, I'm generally seeing, between 1 and 3%, 100 and 300, which is very similar to the Western population. I'm not sure how this differs between the urban and the rural population, and I expect there will be a difference between urban and rural, like you said, between men and women. So I think this is something that needs to be teased out in individual populations, and only time will tell.
Yeah, and we've got a population base now. We've got, I can see Neel's hand and I can see also Eema's hand. I'll come to you. But I think we've got a large enough population to actually look at the rural versus urban, the men versus the women, all the subgroups that you spoke about. So quick comments. Neel, yours first and then Eema. Neel.
So I actually wanted to, since you've discussed these two studies, so in this, have you considered a prior history of COVID as a factor, or is it ruled out in the control group? Like, because we've had a lot of literature showing that even a history of COVID infection, especially moderate to severe, to some extent does cause some confounding with regards to the eosinophilia. So that was the question. Yes.
Yeah, that's a great question, Neel. So we do have, both these studies continued it started before COVID, but continued during COVID. And we have recorded episodes of COVID in these individuals. The counts were done in the stable state though. So even if they had COVID, it would have been a history of COVID, like you said, rather than being active COVID at the time. We will look at that cohort of population. I have to put my hand up, Neel, and I don't know the answer, but it's an excellent question that you ask, and will definitely be one of the things that we look at when we do sub-studies and we look at smaller cohort of population of patients, like the one Murali mentioned or the one you mentioned. Eema, you had a quick point. Did you put your hand up?
Yes, sir. So actually, maybe 10 years back or 12 years back, we were finding a lot of eosinophilia in the typical belt of UP, and people who were migrating from Gorakhpur or Bihar side area. But recently, for last few years, I don't know whether it's a difference in the lab, whether they were doing manually first and now the computerized runs. There's not much of eosinophilia. Though even if you have the range of 4 to 6%, and the people are symptomatic, and if you give them diethylcarbamazine, if they're not fitting into your typical asthma, they are responding. Just to add on.
Yeah, no, absolutely. Brilliant point. The DC point, I think, is very valid, especially in areas where you've got a lot of helminth infections. I think they're very important points. I'll move on. I've got lost in this very interesting conversation that I've lost the count of time. Got about 15 minutes left, and then we'll take lots of questions in the question box. So keep the questions coming. Let me come to a group of patients we have not spoken about till now, Murali. The so-called small airways disease population. That's a population which we are speaking about a lot. We are doing a study on early COPD patients just now. Oscillometry is spreading across the country with like wildfire. And we are talking about small particle inhalation in patients with asthma. So in your patients with GINA 4, GINA 5 asthma who are refractory to therapy, do you actually try and outline small airways disease in these individuals? And if you do, would you try, if you've identified predominant small airways disease, would you try and treat them with small particles? What's your practice, Murali?
So yes, I definitely, when I have identified small airways disease, predominant small airways disease, or only small airways disease, I tend to first decide, am I dealing with the COPD or is this asthma with small airways disease? And if they have asthma with small airways disease, I certainly target them with extra fine particle drugs. We only have one right now, so we use that, and I think it does make a difference. But I think it's also important to remember that if you look at the spectrum, step 1 to step 5, or the mildest to the severest form of asthma, you actually find small airways disease in all these subgroups. And in all of them, even if they're mild, I think it makes a lot of sense to start them on these extra fine particle inhalers to reach the smaller airways and catch them early, because these are some of the most susceptible airways. They're
Sure.
the ones which, when they get damaged, don't recover easily. So that's a group I certainly look at. I start them on extra fine particle medication. And the important thing is you can, with increasing availability of FOT/iOS, we are picking it up a lot more. But we also had an idea about this when you looked at low FEF 25 to 75. So it's not necessarily confined to those who have, FOT/iOS only.
Sure.
We can look at it in all groups.
Yeah. So that's a very important point. Important point to remember. Murali said, look at it in all categories of asthma, because you're more likely to find it in the early categories rather than the late categories. And if you start early, you're probably going to prevent remodeling of the smaller airways much more as compared to doing it when it's GINA 4, GINA 5, and these airways have got remodeled. So important point to remember for your patients with asthma. I'll come back to you, Neel. Brief answers if you don't mind. So choosing between anti-IgE and IL-5 antagonist, I spoke about this during the course of that case, but your thoughts, anti-IL-5, anti-IgE, how do you choose between these two?
So to keep it short, number one, we've already reached the severe asthma where we've checked for the comorbidities. We've done 3 to 6 months checking the inhaler technique, adherence, comorbidities, everything. Now after that, we need to confirm type 2 inflammation. So for that, the markers which you already, biomarkers we've been discussing again and again today, the eosinophilia, the sputum eosinophilia, the IgE levels, the pheno, we need to confirm that this is type 2 inflammation. Or specifically differentiating between the two. For anti-IgE, definitely, as the name suggests, the IgE levels as well as the allergen-specific IgE levels, they need to be seen. Besides that, the IgE for childhood onset asthma, as well as asthma where there are relatively a lesser number of exacerbations, patients with more number of exacerbations, adult onset, as well as patients with a history of with the lung, there is a polyp or any chronic sinusitis with polyp. These are patients who will benefit more with the anti-IL-5 or likely to benefit more with the anti-IL-5. But choosing either of these agents, number one, type 2 inflammation needs to be confirmed, and the cost, that the cost factor is also one of the delineating factors when we are deciding amongst the two. There are some insurance companies now which are covering for the anti-IL-5 agents also, but definitely that is also one of the factors which will be there in besides the scientific indication.
Yeah, grand. Lovely answer. I like the way you sort of discussed in the overlap population what makes you decide, which is the sort of the most important points. And the points that Neel made are very valid for all of you listening out there about deciding between omalizumab and an anti-IL-5 in the overlap population of patients. I'll come to you, Eema, again. Eema, the dosing of omalizumab, this is a biologic we've had for more than 15 years and the most amount of experience. So how do you dose your patients for omalizumab? And then how do you sort of define between a super responder, a responder, and non-responder?
So honestly speaking, I've been reading about omalizumab for years. The dose I'll be guiding you as per the GINA is the vial is of 150 microgram per ml. So when you have a dilution, after that when it is given, the dosing depends on the weight and the serum IgE levels. And for that, the calculators and the cards are given. And accordingly, you give it every 2 to 4 weeks. Even that is mentioned as per your weight and serum IgE levels. And you follow up every time thereon. But practically speaking, even for the last 15 years of my experience and reading through all into the workshops and going through all, I have not been able to give to a single patient because of the cost issues.
Okay.
So in the bed I'm not able to give.
Sure. And so, I mean, what you said was perfect, Eema, and I have actually managed to give it to a lot of patients. I'm sure there are others on the platform who have given it too. But your answer was picture perfect. So the weight, the IG is what makes you decide. 2 versus 4 weeks, depending on the total dose that needs to be given to individuals. The other question was about super responder versus non-responder. You decide that at 16 weeks. That's the time when you decide. And the super responder is whether you've got perfect control of symptoms and you have no exacerbations. A partial responder is someone who has some symptoms, no exacerbations. And a non-responder is someone who's got exacerbations with no reduction of symptoms. So that's ballpark how you decide about omalizumab. Neel, what about shifting to a different biologic? And maybe I'll take an opinion from another person on the panel because this is the controversial question. You spoke very neatly about one biologic versus the other, the anti-IL-5 versus the anti-IgE. How do you decide? When do you decide, okay, this is not working? The patient tells you it's not working. When do you decide that? And when do you shift? What makes you shift?
So when we decide, number one, when we've taken the decision on doing a specific biologic therapy, we have taken that after some consideration. So once we have taken that, we evaluate for the response. Number one will be the symptoms, the lung function test, the biomarkers, the side effects. To some extent, there are some problems also with certain drugs where if a patient has any major allergic reaction or a major side effect with any of the biologics that we've used, then that will be indication. But besides this, majorly the lung function, the patient satisfaction, the symptoms and the biomarkers. This will be the to decide between switching. And definitely when we are thinking of switching, so that means that the drug is still not working. Then we need to go back to our back also. That is there any other comorbidity? We need to revisit our diagnosis also. That is there any other question there?
Perfect. Great answer. So revisiting the diagnosis, making sure that you phenotype the patients again, make sure that you've given the drug for the right duration at the right dose, etc. are factors. You spoke briefly about side effects. I'll come to you, Abhishek. Abhishek, a little bit about adverse effects generally of biologics, but particularly about omalizumab. Is it something that you've encountered, read about, something that worries you when you think about giving a biologic? Or do you consider these are relatively safe drugs as such?
Yes, sir. As far as our experience is concerned, we will consider that when it was started, we were having a dilemma whether it will be give us the hypersensitive anaphylactic reaction or not, and we will be so much of fear when we were giving it. But after using for last 3 to 4 years, now we can say that it is a relatively safer drug. The side effects which we commonly encounter is local side effects like pain, swelling, redness, the bruising at the local injection site, which even only mild and self-limiting. Then general side effects are like headache and URTI, which patient might be having for 2 to 3 days. So we have to counsel the patients that for 2 to 3 days, you might be feeling some uneasiness, you might be feeling some headache, and you might be feeling some symptom of URTI. So these are the general symptoms patient might be having. And as far as serious reaction is, which is documented in the references, is anaphylactic reaction, which we have not encountered till date. And now, if we talk about the other these biologics like mepolizumab, have the reference stem that mepolizumab and this resolizumab have a tendency to reactivate herpes zoster infection if patient is having this herpes zoster in the latent phase. Some literature also say that like benralizumab can have an increased tendency of this helminthic infection. If patient is from this endemic area, we have to counsel them and we have to check for these reactivities of the helminthine infection. If it is dupilumab, which is not still available in India, but I read about this in for this webinar. This dupilumab having the side effects of conjunctivitis specifically and hepatitis in some rare cases. So these are very reference. The reference suggests that these are the side effects, or these are the written side effects. But practically for omalizumab and which we are using frequently now, we have not faced any major side effect till date.
Yeah. So completely agreed, Abhishek. That's very nicely put. I love the way you outlined the important exceptional side effects of individual drugs. But carry home message, these are safe drugs. They can be used safely in most individuals. And anaphylaxis is something which is almost unheard of. I've used these drugs for 15 years, never seen anyone having anaphylaxis. I can see Murali nodding his head in agreement. So I know that there's a lot of confidence that these drugs don't cause anaphylaxis commonly. I feel alarmed. I see Neel raising his head. You've seen someone with anaphylaxis, Neel?
My question is mainly not for anaphylaxis, but since you'd also discussed regarding Montelukast also recently, that regarding the side effects. So my question is regarding the medico-legal part of these things, that in such a case, suppose your patient is on more than 6 months of Montelukast. FDA has issued a warning even for omalizumab. In 2014, there was a warning that it is high risk for causing heart attack, stroke. Now, in 2024 is the year that omalizumab has received an FDA approval for severe asthma. This is the year. So my question is that in such cases, especially when we are not talking about specific the biologics, but patients who are on long-term Montelukast, like you said, that in some cases psychiatric evaluation is needed. So now in patients who are on long-term, would you recommend that definitely, like for ethambutol, say optic neuritis, we get a ophthal evaluation done? So for Montelukast, would you also recommend? This is just a question out of in practice for patients who need long.
Yeah. So Neel, I'll tell you what I do. I definitely look at I look at the previous medications the patient is on in every patient, not just these patients, but you would want to look out whether there's any psychiatric issues or not. And I do ask the question about anxiety because it's also relevant to your patients with asthma. You know, about anxiety, about depression, about social withdrawal. You would ask those questions and you would document it. And you would forewarn the patient that if on these drugs you feel that these psychiatric issues that you might have or might not have are appearing or worsening, please come back and report to me. I think if you document that, even from a medical legal side, it's good practice, of course, but even from a medical legal side, people understand that you've checked for it and recognize the fact it might cause a problem. So that's what I do in my clinical practice, Neel. I have the most difficult question for you, Murali, the answer for which I'm still looking for. Choosing between Benra and Mepo. How do you do it? What are the factors? How do you go about choosing between these two agents?
I think it's fairly simple. Both are equally effective. All the studies have shown that one is not superior or not inferior to the other. So very often, can I be frank? It depends on when I ring up the company rep who responds first. You know, because I think there's really very little difference.
Sure.
There is a small difference in cost, and that difference will even out over time. And so I just go by, who responded first. I participated in the benralizumab trial. So that's often the first person I will ring up. But, in my experience, whether I've used Benrali or Mepoli, both seem equally effective.
Yeah.
When you look at the eosinophil counts, I'm a little concerned because with Benrali, you get virtually zero eosinophil counts.
Yeah.
With Mepoli, you still have some degree of eosinophil, still active. Not sure how actually effective they are because you've blocked off the receptor, but you still find them. And that gives me a little source of comfort. But in actual terms, I don't think you're really seeing much of a difference.
Yeah. I agree with you. I mean, I've used both and I feel comfortable using both. And I mean, maybe the other factor is the Benra, you can use it every 2 months, second month. So the duration of getting these injections is also lesser. But I think you're sort of nitpicking. There's no hard evidence to choose between the two. And I think it's still watch this space. A quick word from you, Suprova, about the dose of Mepo versus Benra for the audience who are looking to use this in the future.
Yes, sir. As GINA suggests that mepolizumab is 100 mg sub-Q injection 4 weekly for more than 12 years of age and adults. And from 6 to 11 years can be used 40 mg sub-Q injection 4 weekly. And
Yeah.
for coming to benralizumab, it is the dose is 30 mg subcutaneous injection for first 3 doses, 4 weeks apart. After that, 8 weekly once,
Yeah.
30 mg subcutaneous injection. So that is as per
Perfect.
GINA.
Perfect. Thank you, Suprova. And I'll ask you about Dupuli. Any thoughts about Dupuli, Abhishek? That's one of the drugs that will be available by the end of this year or the beginning of the next. So, where would you position it? Do you think it's got any use after what we have got, or do you think it's just adding on and just a toss of a coin, like Murali said?
Yes, sir. So I read about something about this, and literature suggests that this is an anti-IL-4 drug. So this is the biologics work on the pathway of the IL pathogenesis of the cytokine release. Now, if we understand the pathology in patients of asthma having a atopic dermatitis and patient having chronic rhinosinusitis because of the nasal pollens, these two sets of patients having the same pathogenesis of IL-4, this pathway. So, logically, rationally, we can say that whenever this drug is available, the cost I don't know, and the route as well as I don't know. But whenever it is available in this set of patients, we talk about the phenotyping everywhere now. Phenotyping is everywhere now in ERDS and ventilator also there. So whenever we will having a patients of severe asthma who are having a comorbidity like atopic dermatitis and chronic rhinosinusitis with nasal polyps. In this set of patients, these Dupilumab looks having a safety profile as compared to mepolizumab or benralizumab.
Yeah.
So logically, and literature says that this drug will be useful in this set of patients. Logically, I can also think that in next few years, we will be having a recommendation GINA even. That the present recommendation is that we have to use these biologics only after we have exhausted all our resources.
Sure.
In step 4 and then only step 5. But in next years, I think logically I can predict that there may be some recommendation in some set of patients, like in severe asthma with comorbidity, which is needing a very high dose of inhaled corticosteroids. Even in step 4, we will be using these biologics. So this might be the developments in the future. So this is my rational thinking, which I can predict.
No, Abhishek, I think that's a great point. The fact that inhaled corticosteroids are now used in step 1 of asthma. So the aim of using the drug is not to use it when everything is lost, when the airway is remodeled, when we have lost lung function, but use it before so that you can regain lung function. That's a very, very valid point that you made, Abhishek, and I'm glad you made it. A line about tezepelumab as a broad spectrum biologic, Eema? Anything that you want to mention about tezepelumab? That's another biologic we'll have in about 1.5 years' time. So
one is that GINA mentions that it is only to be used after the age of 12 years. Second is that still yet to come. Once it comes, like you all are seeing that there is a big difference in the biologicals. So maybe that would be one of the greatest things again. Hopefully it will be into our feasible market area. And once it is there, then we'll have to see according to our country, our ethnicity, our kind of people, whether they are good responders to such a drug or not. So again, one of the researches by you would be required on those.
So I think neutrophilic asthma would be that one space that you would really look for. I mean, we are really lost for treatment when we think about that category of patients. But like you said, I think it's still early days and we need to find out about the use in our population of patients. Coming to the fag, and we've got some questions that we need to ask, but I'll come to Murali with another question which is frequent. A lot of us do this in clinical practice without evidence. So you've got someone similar to the patient I described, Murali, someone who's well on biologics, been a responder or a super responder, now puts up their hand and said, cannot afford the biologic anymore. I'm sick of taking the injections every month. What do I do? So what about reducing the dose, reducing the frequency? Do you do any of these? Or do you say you have to stick on it? If you don't, then I don't really know what the future holds for you. What would you do, Murali?
So I think the first and most important thing is you can't stop it too soon. An initial assessment starts only after 4 months. So upfront we tell them, look, I'm going to give it to you only for 4 months at least before I will tell you you're going to feel better and whether to continue it or not. Now the person's got better. I would continue it for at least a year and then ask them to come back for this discussion, because there is, it seems logical that after you used it for a year, you've reduced the dose, the inflammation substantially. You should probably be able to, as you said, rather than reduce the dose itself, I would reduce the dosing frequency and try again. In the meantime, you also have the opportunity again to optimize the drugs. And now that you've got the patient's confidence that he or she is better, you might be able to persuade them to be more adherent to treatment. So I think in our country, given the cost issues, it's certainly a possibility. And this we've seen in the patients. So we recruited mostly poorer patients for our benralizumab trial. And we had to take them off because they couldn't afford it after the trial period. And they've done reasonably well with some recurrence of symptoms. The eosinophil counts have crawled back up a little, but they're still doing very well, much better than they were before. So I'm fairly optimistic that after a year of treatment, I will be able to cut down the dose. The dosing frequency can be increased, and I may be able to take them off it completely in those who cannot afford it at all. The other intriguing thing is whether you can move from, and there's no evidence still on this, I think, where you have a person under good control who has the overlap of the high IgE, high eosinophil population, whether you can de-escalate, as it were, from one of the anti-IL-5 agents to the anti-IgE agent and still maintain control. But this isn't that small group.
Sure. Yeah. Grand. So that brings me, that's beautifully put, Murali. I think all of us do it. The alternate month one is something that I've done post 3 years in a few of my patients, and there's a bit of data that you can do it beyond 3 years because control seems to remain for a bit longer beyond 3 years. That's what the data we are extrapolating from. But the important point that brings us to is when you're stepping down on the inhaled corticosteroid while maintaining good control, are we aiming for remission, Suprova? Do you think we can actually come off inhaled corticosteroids while on biologic therapy when you're stepping down with perfect control? Or would you still keep them on a small dose of inhaled corticosteroid and continue with the biologic? What is it that you would do, Suprova?
Yeah, sir, first, I think the target should be on OCS. That oral corticosteroids should be,
Sure.
the target is completely tapering off.
Yeah.
And then to assess the each and every medication given in that particular patient's prescription. For example, if a LAMA is added to LAMA, should be stopped cessation should be first. And wait for few days if asthma is stabilized. Then a little bit lowering of high dose is can be tried, and again the time period should be given at least to stabilize the asthma. As each changes happen to the asthma prescription, we have to wait for the time, but it is in a consensus said that beyond going moderate dose of ICS is not very much recommended, because after withdrawal gradually the effect will wane off of the biologics, and that time the patient may have all very acute exacerbation again, and the symptoms may come back. So it is not advised to stop ICS at all. It can be reduced slowly up till medium, or maybe for some patients low dose with the deliver mart.
Yeah. So
But
great
the
answer,
target
Suprova. I agree with you. I think coming off steroids probably is not an option in patients with asthma. And I think that is a strong message. I think the way we are speaking about remission in asthma today is different to the remission that you speak about in patients with rheumatoid arthritis or inflammatory bowel disease, where you can come off drugs. I think we are still far away from that in asthma. But I think with biologics, you have the capability to coming down on minimum dose of inhaled corticosteroids while staying on the biologic. And then maybe there'll be trials where you reduce the frequency of the biologics in the way that Dr. Murali Mohan spoke about. We're coming to the fag, and we'll take some questions and then we'll finish in the next 5 or 6 minutes, I promise. I've got a $1 million question for you, Neel. Question about the ultra LABA or the ICS, which we have not discussed at all. And the reason we have not is because GINA also keeps completely silent about this drug. So we've got various combinations today. The question in the box happens to be about vilantrol and fluticasone, but there's multiple combinations that we know of today. How do you position these? And if you do use them in asthma, would you use formoterol budesonide as rescue in these patients, or what would you use as rescue in these individuals, Neel?
So the question is regarding the ultra LAMA. So normally
ultra LABA ICS, correct? Yeah, ultra LABA ICS.
Ultra LABA ICS. So normally in patients where, again, as long as we don't have any definite recommendations to any specific molecule, but in specific, where I saw one question was also regarding asthma post-COVID. So
Yeah.
Vilantrol specifically, when we talk about that one molecule, so there was a discussion regarding the drug interactions also with Vilantrol, that in a lot of antivirals, especially the newer ones which were used, nirmatrelvir, ritonavir combination, or even molnupiravir to some extent, there was a risk of a cross interaction with Vilantrol. So in such cases, number one, there has to be, if there is a post-COVID or an active COVID situation, then that drug interaction needs to be known about. Second, that in patients with, if a patient's control on an ICS LABA is good, formoterol budesonide is good control, then we definitely need to go up. If the patient's symptoms are worsening, it is a type 2 eosinophilic asthma, we would like to go up on the dose of the steroid than the shifting to an ultra LAMA agent. Probably compliance wise, duration wise, in some cases we find that when a patient has issues with compliance or adherence with a twice daily combination, and you need to shift to a single daily combination, then in such cases an ultra LAMA may help with the compliance in specific cases. However, for differentiating between that specific to Vilantrol, we need to wait for more studies to recommend that, okay, we will shift in a patient from one LABA ICS to a ultra LABA ICS combination. This is again not completely, evidence is not available, but this is what I would follow in practice. Yes.
Yeah, great comment, Neel. Suprova, quick comment.
So there is one study particularly about this one, fluticasone and Vilantrol. So it was compared with high dose fluticasone Vilantrol versus the moderate dose fluticasone Vilantrol and umeclidinium. When combined, so this triple drug was better. And if we are using the Vilantrol and fluticasone combination, so as a reliever, this patient has to use the ICS-SABA combination. They are not allowed to use the formoterol budesonide, not recommended. So in that case, this is not an ideal combination. That is, high dose fluticasone and Vilantrol won't be advisable. Rather than formoterol budesonide glycopyrronium can be tried, so that formoterol budesonide can be given as a reliever as well.
Sure.
My point, sir.
Sure. So I'll give you my two-penny word, which is basically the combination of what both of you are saying. I think there's not enough evidence just now to position these drugs in GINA. We have tried to do it, and we have tried to give it in stable patients who are happier with once daily formulation. So you're on an ICS and a LABA, you say, I don't want to take the drugs twice a day, doctor. I'm too busy. I cannot do it. You offer them an ultra LABA and an ICS. But if they require too much of rescue medications, I think you need to go back to the conventional ICS LABA again, where rescue medications can be used with much greater evidence. I think that's how we stand today in this particular area. Dr. Indu Bubna, my friend from Maharashtra, she's asked about role of pheno. I think we spoke about Th2 inflammation. There's certain biologics where a high pheno predicts response. Omalizumab is one of them. So there was a study which looked at the level of pheno above 20, it was actually 19.5 above and below. And they showed that patients who had a pheno of above 19.5, let's say 20 for the sake of measurement, they responded much better in reducing exacerbations as compared to people who had a pheno of less than 20. So there's similar examples with other drugs, other biologics, but that's how we use it in patients with asthma. There's a question about steroids. Maybe I'll ask this to Abhishek. Oral steroids, what is the role, duration, maximum duration? And there's a bit which I'll answer so that I reduce your work, about single dose triamcinolone, single dose hydrocortisone, whether they have a place, and if so, how many times. So just to say, they have no place. Once IM dose, we used to have this Decadron Derifile in Kahani. Maybe in our childhood, you guys might not have seen it. Murali and myself, we would have seen that. That was standard prescription, but they are bygone era and is no longer valid for prescription. But Abhishek, what steroid, how many days, how would you use it in an exacerbation? Oral steroids, Abhishek.
So now, 24, this GINA guidelines says that there is a role of oral dexamethasone also. And if we talk about oral dexamethasone in severe exacerbation, if we want to use it, we have to use in 12 milligram per day and only for 2 days only. So as far as duration is concerned, dexamethasone we can use only for 2 days. And if patient is requiring the more than 2 days of steroid, then we will have to switch over to oral prednisolone. And we can give it for at least, I think, if more than 7 days, then we have to taper off for at least 21 days. But what we do usually in tapering dose of steroid. So this is the standard thing. Whenever the patient requiring the longer duration, the longer treatment for oral corticosteroids, we can give for 3 to 6 weeks. And in rare cases, we can also give for the 3 months. And then we have to switch over. We have to definitely go check for the tapering off and stopping these oral corticosteroids by any how. So this is the recommendation which GINA has.
Perfect. Yeah. Thank you, Abhishek. Thank you very much. That's great. Maybe a couple of last questions. One to you, Murali. Shorindranath Banerjee asks, how do you manage high IG in a patient with moderate asthma? I take this as being sort of spirometry moderate asthma with regular medications, high IG of more than 1200 and a CT which does not show bronchiectasis.
So there are two possibilities you're dealing with. One is you're dealing with the ABPAS, which is just a sensitization. So I'd first be looking at the Aspergillus specific IgE and IgG. So that would be the first step I would do once I have a high total IgE. The other is, of course, if the patient is very well controlled, obviously the first thing is to try and get him from moderately severe asthma and moderate control. I think the important thing is to talk about control at this stage. If they're well controlled, I would leave them alone. I wouldn't try and target anything specifically, but I would keep them under careful follow-up and look for evidence of ongoing damage. The second, of course, is if they're not very well controlled, I would focus on the control. And following the same number of steps that we usually use, I think IgEs are a marker, and what we are treating is the patient and the infection. I wouldn't be treating the IgE alone.
Yeah, absolutely. I think that's a very, very valid point. There's another question. Our friend Dr. Ajay Lanjevar has asked a lot of questions, but one about COVID and asthma. And I think that's been highlighted by Neel in some detail. So we'll give that a miss and we'll go to one from Dr. Sujata Sarda, who asks, and let me ask this to Eema, is there an importance of differentiating severe asthma in farmers who have seasonal exacerbations related to farm work and viruses and so on? Do you think they are a different population, or would you treat them no different to what you would do for your standard patients with asthma? Eema.
So the farming related things would be the triggers for these asthmatics.
Sure.
And so we'll have to control them as any exacerbation we go in for. Obviously, since it is related to their work or it is kind of occupational asthma, we cannot tell them to move away from the occupation. We can guide them on the triggers, how to avoid, best avoid. They cannot leave the occupation, but how to best avoid. And in case they have, treat it as a severe exacerbation kind of thing.
Yeah, grand. I think that's perfect, Eema. Finish off with concluding comments. Maybe we'll start off with you. Murali, please.
I just wanted to say, let's be careful that we're not dealing with the hypersensitive pneumonitis, somebody who has these symptoms.
Absolutely. It's not chronic HP. So quick one-liners, and if you can just have a one-line message from each of you. Let's start off with Abhishek. Abhishek, a one-line message you want people to remember after our severe asthma symposium.
In this era of phenotyping, before stamping severe asthma, please confirm this is not difficult to treat asthma. Then only go for the treatment protocol for severe asthma.
Lovely. So define that less than 5% population which you talked about. Suprova.
Severe asthma can also be controlled. So just try to identify the factors and follow up with your physician.
Yeah, wonderful. Great message. Eema.
So two things. One is that I found the newer age stethoscopes as useful to help these people be marked as asthma. The attendants are able to recognize the wheeze if you are able to put them on your app. And then once they're controlled, they feel, yes, that has been controlled. The message is always before making such a diagnosis of severe asthma, see whether your diagnosis was correct. The patient has followed up, everything was correct. And then only make and go further regarding the further treatment with biologicals and other drugs.
Yeah, grand. And also the message from you, Eema, that do use your stethoscope. Please don't make it vestigial even now. I think that's also a message, right? Neel.
Sir, my take-home message here would be that number one, your diagnosis of asthma has to be correct. Then ITC, 3 letters we remember. One is the inhaler. Everything about the inhaler has to be right. The trigger has to be removed and the comorbidity has to be treated. So if you follow these ITC, And then definitely, so rather than, then we will come to the aspects where we diagnose the severe and the treatment of severe where needed. But we need to ensure that we are defining it properly first.
Yeah, love that ITC. Great, Neel. And then to the Einstein of pulmonology, Dr. Murali Mohan. Murali, always your last wise words.
So great messages from everyone. I think the important thing is, while biologics are expensive, the cost of asthma to the patient, to the family, especially somebody who's having exacerbations, missing work, and getting hospitalized, is often much more than the cost of the biologic. So when choosing a biologic, be very careful that the person needs a biological, but when he or she needs it, don't hesitate to prescribe it for economic reasons.
Yeah, grand. So remember, I think severe asthma is a small subpopulation of patients that you will see, but you will definitely see them. Try and classify them right, treat them right by phenotyping them early. And like I think one of the important points which Abhishek made, try and diagnose disease early, try and use drugs early in the disease process, rather than waiting for the severest of disease and using drugs, where using any drug might not bring you the benefit that you want to attain. So thank you very much. I had a lovely time. So thank you to Murali, Neel, Eema, Abhishek, and Suprova. Big thank you to the Zuventus team for having supported us through this webinar, and the CCI family rocks. A special thank you to Dr. Krishna for making an appearance during the course of the meeting. Loved being a part of this meeting, and I hope we'll have another meeting where I can participate in the not so distant future, and look forward to next Thursday. Thank you, guys, and good night.
Thank you for some superb moderation. Absolutely super. Thank you so much.
Thank you.
Thank you so much, sir.
Thank you so much.
It is always a pleasure.